All right. So, and you were going to do an introduction, Stephanie?
Yeah, I'm just waiting for a few more people to join in and then we'll kick it off. So
Cool.
just
Perfect.
we'll just leave a few seconds and we'll get started, everyone.
Awesome.
All right, well, welcome everybody. My name is Dr. Stephanie Wu. I am the founder of Wu University, and it's my pleasure to host this exciting program. And I think you are going to be so happy with what's in store for this evening's education. If you need COPE credits, then you're going to make sure to take one of the surveys that is going to be inserted into a chat box throughout the presentation. And you have to remain on for at least 50 minutes. We will be generating the certificates and delivering them to you by email over the next few days. Could take up to a week. So please give us some time to get those done. And tonight's program is about myopia management in practice, and Dr. Ariel Cerenzie is going to be talking about treatment management options. And this is such a hot topic, and I'm really, really excited to hear from her. So without further ado, Dr. Ariel Cerenzie, she earned her Doctor of Optometry degree from University of Houston College of Optometry. And then she developed a passion for specialty contact lens care. She pursued her passion further and then completed a cornea and contact lens residency at the University of Missouri, St. Louis. And during that residency, she gained not only experience on irregular corneas, lots of different types of specialty lenses, but she also became very passionate about orthokeratology and caring for the pediatric population. She is a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. She's also a member of the North Carolina Optometric Society and the AOA. She's now practicing in North Carolina, Charlotte at Vision Source Studio 2020, and has helped to grow a large myopia management specialty within the practice. She's also almost ready to have a baby, so a true amazing powerhouse woman leader in our industry, Dr. Ariel Cerenzie.
Thank you, Stephanie. I appreciate it. So, hello, everyone, and thank you for joining tonight. This is going to be a 1 hour continuing education presentation on really part two of a two-part series. The first part, we covered, why myopia happens in some folks and why it doesn't in others, some of the risk factors for myopia development and fast progression, as well as some of the disease that we are at risk for with myopia and why that exactly happens. And this part is going to focus on, what when somebody is either at risk for myopia or has myopia, what we can do to intervene to ultimately provide them with the best vision and ocular health outlook for their future. So as Dr. Wu mentioned, I'm currently pregnant and due in just a few weeks now. So we're super excited to welcome a little girl into our world. I practice in Charlotte, North Carolina at Vision Source Studio 2020, and really have enjoyed building up our myopia management specialty clinic there. For the presentation, we're going to discuss early intervention strategies. So if we identify somebody that is at risk for myopia, what are some of the things that we will do? What are some of the conversations that we'll have? Next, we'll talk about some of the contemporary myopia management options and how well they work. And then we'll talk about some combination therapy options, then what's on the horizon. So what is happening in the future of myopia management? So first, let's talk about patients that may not be myopic yet, but are certainly at risk for becoming myopic. So this is a little bit of a review from part one. From the CLEAR study, we know that refractive error at a certain age is really the most significant risk factor for the development of myopia, more than genetics and near work, indoor time, et cetera. So if you look at that chart on the left, If a child is more myopic than the refractive error that is corresponding to the age, there's a very high likelihood that they're going to become myopic when they get older. Other risk factors are if one or both parents are myopic, how much near work that we're doing. So not only the cumulative amount of near work that we're doing, but also more importantly, the continuous work that we're doing without taking any breaks. So, a lot of kids are gamers now. So that would be an example of they're already doing a ton of near work at school, and then they're coming home and not spending time outdoors, but instead being in front of another screen. And then lack of outdoor time, lots of indoor time is another risk factor. So when we see some of these risk factors and we want to hopefully either prevent them from becoming myopic or ultimately reduce their ultimate level of myopia that they develop, we'll want to recommend a few things. And one of those is to increase their outdoor time. One of the studies shows that if they can increase their outdoor time to about 2 hours a day or a total of 14 hours a week, that will have a really good effect, hopefully, on delaying or preventing any sort of myopia onset. As far as near work, you want to talk to the parents about when they're doing near work, how close are they to their near work? Are they like this kid on the right where they're basically their faces on their paper? And if so, we really want to make sure that we encourage a reasonable working distance. So sitting back a little bit from the paper will reduce the ultimate, dioptric demand that eye is having to that near object. The second is to make sure that we're doing near work in adequate lighting and that we're simply taking breaks, like every 30 to 40 minutes. If they can take breaks from near work, then that will hopefully help to delay or prevent the onset of myopia. And if we identify these risk factors, we probably want to see them sooner than 1 year. So depending on how many risk factors they have, maybe you see them at 3 months, maybe you see them at 6 months, but you probably want to see them more than an annual basis. And what that really provides you with is the opportunity to introduce myopia management early. Sure, you're not going to treat a kid that's at risk for myopia, that's hyperopic right now with myopia management. But if you start a discussion with them, the parents are certainly a lot more open to myopia management interventions when that time comes. So I actually developed a script that I wanted to share with you guys on a discussion with parents that I found to be really effective. Short, but not too short, succinct, because I'm kind of a rambler, but provides them with enough information to take action and to understand the importance of following up. So I'd say something along the lines of, we expect your child to be within a certain range of normal vision development, and unfortunately, they are outside of those normal ranges. And your child is at increased risk for something called progressive myopia. And what that is where their vision gets worse every year, and they need thicker and thicker glasses, and they're more dependent on these glasses. But the good news is that if we catch it early, we can slow down their vision changes. So let's schedule a 6-month visit and make sure that we're headed on the right track. And then I'll talk to them about breaks from near work, outdoor time, etc. The reason why it's important to have early intervention is because the earlier the onset of myopia, the faster progression we will have and the higher the ultimate level of myopia that this child will have. So this was a study where they looked at 930 children and followed them over a course of 6 years, and they followed up until the age of 11. And if you look at the red portion of this graph, you can see that if a child is starting off as a -0.5 at the age of 5, by the time that they're 11, they're already a high myope. So if we could delay that by a few years, it makes a significant impact on their overall rate of progression, but also the ultimate level of myopia that they'll have. And this is just to the age of 11. We know that myopia continues well beyond that age. Usually anywhere from 18 to 21 is when most kids tend to stabilize. But as we know, we see adults that are still continuing to progress. And so this study concluded by saying we can't really predict when an individual child will really stabilize, and we'll probably need to keep them on interventions likely through their mid-20s, or just when you start to see that they're showing good stability. I'm sure you guys have had a similar experience in optometry school. You know, a lot of my friends, they increased by like a diopter or more over the 4-year period that we were in school from all of the studying and near work that we did. So what are some of the options that we have? We'll first start with what we don't want to do, which is undercorrection. We used to think that undercorrection would be helpful in preventing in slowing myopia, but there are several studies that actually find that it may make myopia more progressive if we undercorrect. So the chart on the left are children that were undercorrected by a half diopter. And then the chart on the right were those that were undercorrected by 3/4 of a diopter. And you can see that they progressed more than those that had full correction in. So we don't want to undercorrect. Some of the spectacle options, we'll see that these really aren't super effective, but they're definitely better than doing nothing if the parent isn't ready to do atropine or contact lenses for their kids yet. So we'll go over some of those studies. There are quite a bit of studies on progressive addition lenses, and they really, on average, slow myopia by about 20%. But you can see in the COMET study, there's this little subset group that did a lot better than the rest of the myopic children. And that specific subset did have a large esophoria and a large accommodative lag. So they concluded by saying, you know, it's progressive addition lenses really didn't have much of a clinical impact in terms of their stability. But if a child has a large esophoria or an accommodative lag, then they can be a lot more effective. Next, with the bifocals, I think that was a 28 seg bifocal, there was only about 20% control. And there was a little bit more control with the executive bifocal. In this study by Chang, they had a little bit different of a group in that the children in this study were actually already progressing. So they specifically chose myopic kids that were already progressing in the prior year. So we probably would see less of a percentage control if we were to include all myopic children. But nevertheless, they saw about 51% control with a plus 150 executive add with 3 diopters of base and prism built in. The issue with that is, you know, you probably don't want your kid to be in an executive bifocal just cosmetically. And they are kind of hard to come by in terms of making sure that you're getting the appropriate material for children in an executive bifocal. So if you have to go the glasses route, I would say just try to prescribe the largest seg possible. And know that if they have a large esophoria and or a accommodative lag, perhaps you'll get a better effect. But we know some of the more clinically proven and effective modalities are our multifocal contact lenses, our orthokeratology lenses, and then atropine. So what tools do you need to have some of these more effective therapy options? The first we all have the ability to do, which is a cycloplegic refraction. As far as cycloplegic refractions are concerned, I probably don't do it as often as I should. There are definitely proponents out there that it should be done every time that they come in. If I find something that's kind of hidden with this cycloplegic refraction, then I'll do it more frequently, but typically I'll do this like on an annual basis, especially if the child has a reliable subjective refraction. But you'll find various sorts of recommendations in different studies that are read. If you're going to do orthokeratology, you'll definitely want to have a topographer to be able to troubleshoot fits, to be able to make sure that your fit is appropriate as well. For atropine, you'll want to have access to a compounding pharmacy. There are two companies that have readily available low-dose atropine, Optum RX Pharmacy and Imprimis RX Pharmacy, and they'll have some of those more popular low-dose percentages available, like the 0.01, 0.025, and 0.05%. And they make it pretty easy for you to be able to prescribe those to patients. It's always great to support local too, if you have a local compounding pharmacy, but you want to make sure that one, they're a sterile compounding pharmacy for ophthalmic products. And also that they have some background knowledge on atropine because it is an unstable compound. So it has to be diluted in a pretty specific way. And then lastly, biometry. I should put a little asterisk by that because that is pretty debatable on whether you need it or not. I certainly think that you don't need it to be able to practice myopia management, but it does give you a little bit extra information than if you were just to do a refraction. So it's a nice to have for sure. Some of the proponents of biometry, their arguments for needing it for myopia management are, there's multiple. One is that it provides you with an objective form of information, kind of like with glaucoma, we have our OCTs and our visual field. Our biometry offers us, something that the kid doesn't have to give their subjective response to. Another reason why some people are proponents for it is because we can start to actually see when kids are becoming myopic before they actually become myopic with their refraction. And what I mean by that is if you look at a child who is hyperopic, those that will become myopic will have a very quick increase in their axial length compared to those that will ultimately not develop myopia. And so it gives you some insight on how to perhaps change their follow-up protocol. Another proponent or another reason for it is, as we'll go over with the ATOM study, the atropine 0.01% showed great effect with the refractive control of myopia. But for some reason, the axial length change did not line up with the refraction hardly at all. So that was, I don't think anybody really understands why that happened, but that was consistent with both the ATOM and the LAMP study, that axial length and refraction just didn't line up like we thought that they should. It is nice to be able to also talk to parents about growth charts, because this is something that they have been familiar with when their child was a baby. And so you can show them charts like this and show them where their child is in what percentile they are. And it just kind of helps to have an extra resource and an explanation as to why this is important and that this is not normal for their child's eye. So this is one of the normative growth charts that's available. And the males are on the left and females are on the right. So you guys can download that from the resource that's in the bottom right of the slide. So multifocals. For multifocals, our two daily disposable options are the MiSight and the Natural View lens. Two monthly options are the Biofinity Multifocal D and the ProClear Multifocal D. And then our 2-week center distance option is the AccuView Oasis for presbyopia. The center distance just has a lot more data behind it in terms of how well it works versus the center near, which is why I didn't include any of the center near options. So based off of what type of lens that you're on, they all deliver a plus in the periphery of the lens that brings the optics forward in the peripheral retina. So multifocals do this optically, and it depends on what type of multifocal you're prescribing on how that is done. So the AccuView Oasis and the MiSight, for example, is more of like a concentric ring, and the Natural View is kind of more of a gradual increase in plus. So let's see. This was a really cool study by Dr. Walleen and Dr. Walker on how the different ads may affect the level of control of myopia. And so they put nearly 300 kids in 3 different types of contact lenses, either the high ad power, medium ad, or a single vision. And these were all bioaffinity multifocal center distance. So the high was the plus 250D, the medium was the plus 150D. And they watched him for about 3 years. So the thought is that the high ad would have more control because it's bringing the myopic defocus further away from the retina than, say, what the medium ad does. And they did find that the higher the ad power, the more level of control that they had. And for the bioaffinity multifocal, they found that there was about a 43% reduction in the progression of myopia. With MiSight, the folks at Cooper designed the MiSight lenses different than the bioaffinity multifocal D. And they have, so that basically the light purple are what provides the good vision with the correction zones. And then the dark purple is our treatment zones, which is about a plus 150 diopter ad. So they had kids ages 8 through 12 with a refraction between 0.75 and 4 with less than or equal to 3/4 of SIL. And they randomized the group into either MiSight one day or ProClear one day and found a really great reduction in the progression of about 59% for the refractive error and about 52% in the axial elongation. And they found that it was a really safe option, that there were no cases of any sort of adverse ocular events, infections, vision loss, etc. And what's really cool is after 6 years of data, they found that 23% of those children didn't progress at all. They progressed less than 1/4 of a diopter. And over that 653 wearing time, it still continued to demonstrate a great safety profile, wearing time, and the kids really tolerated it well with visual acuity also. So I think, with MiSight, that's been a huge thing for our profession, that we now have an FDA approved option to provide to patients that is safe and very effective. And it makes it a lot easier to be able to talk to parents about myopia management with this option. Safety of contact lenses in general, there are a few studies that looked at this, the Clay study and the Recess study, trying to basically see, is contact lens wear more safe in adults or kids? And they actually found that children showed a lot safer contact lens wear than what their adult counterparts do. In the Recess study specifically, there was less than 1% incidence of any sort of adverse effects. And some of those adverse effects may have not had anything to do with the contact lenses, may have, but conjunctivitis, foreign body abrasions, but there was no vision loss that resulted from them. They did conclude by saying that if you're going to do a soft contact lens, it's preferable that you do a daily disposable because solutions and storage cases can be a major risk factor for infection and inflammatory events. Orthokeratology reduces the progression of myopia by about 50%. And depending on what meta-analysis you look at, it's about 41 to 46%. And it does so by changing the optics of the cornea itself. It doesn't do that through, physical manipulation of the contact lens to the cornea, but rather through hydraulic forces that redistribute fluid within the cornea. And you really want to make sure that for a myopia control ortho-K lens, that treatment ring is in the pupil or at least at the border of the pupil, so they are having that myopia control effect. Whereas when you're doing it for an adult, just for myopia correction, as opposed to myopia control, you would want to have that ring on the outside of their pupil. That way they're not, complaining of a lot of glare and halos. And there are several companies that do provide, specific types of designs that will provide that treatment zone within the pupil for you. So overall, with the safety of orthokeratology, there was a lot of misinformation out there from really Southeast Asia. And, there's a lot of doctors will mainly, I see it a lot from ophthalmologists where they kind of challenge you about orthokeratology safety. But if they are, then they haven't read any of the updated research, because we know that it is safe from all of these huge studies that have been done. But there were several case reports coming out of Southeast Asia of these terrible infections that happened in children, mostly in China, because they were just cranking out these lenses and not teaching the kids how to take care of them, how to clean them, etc. So when you look at the studies out of America and American kids, you see that it is safe, just as long as the fitter is making sure that the lenses fit correctly, which is really easy to do with all of the modern designs we have available now. That you're making sure that they're cleaning their lenses properly, which is very easy to do now also with some of the hydrogen peroxide systems that we have, that they're coming in for their follow-ups, and if there are any complications, that you're treating them very quickly. And in a study done by Dr. Mark Bullimore, he found that there was less than 1% per patient wear year of any sort of, adverse event happening. He did, if you guys like podcasts, he was on a podcast with Dr. Chris Wolf recently on iCode, and they talked about this specific study. And Dr. Wolf asked him, if there were any cases of frank infection or MK, and Dr. Bullimore said no, but they did have to report some of like the inflammatory events like corneal staining as a quote unquote like risk of microbial keratitis. So most of those adverse conditions were just a little bit of staining of the cornea. For atropine, atropine does have a dose-dependent response. So the higher the concentration, the more effect of myopia control we have. And I'd like to go through 3 of the main studies because it helps to kind of determine, why we are where we are with the concentrations that are recommended. So the first big study was the ATOM study. And in this ATOM study, they had 400 myopic kids ages 6 through 12, and they randomized them to either 1% atropine or saline for 1 drop every night for 2 years, which sounds awful for those poor kids. If you look at the chart on the right, the triangles are for the ATOM 1 study. The circles in between there are the ATOM 2, which we'll get to in a little bit. So just ignore those for now. But over the course of a 2-year treatment, they found that the 1% atropine slowed myopia by a whopping 80%. So they discontinued the drops at that 2-year mark to see if there was any sort of rebound. Unfortunately, there was a huge rebound where basically the 1% nearly got to where the placebo was at the 36-month mark. So they knew that we obviously couldn't have somebody suffer on 1% atropine and then just have them go back to where they would otherwise if they weren't to do anything. So then the ATOM-2 study came out and they randomized the patients into groups of either the 0.5%, the 0.1%, or the 0.01%. And the reason why you don't see a placebo here is because the researchers thought that 0.01% would be the placebo. And their goal was to compare the safety and efficacy of some of these lower doses of atropine. So let's look at our right graph there. You can see that the higher let's go to this one. The higher the percentage, the 0.5% is the black, the 0.1% is the gray, and then the 0.01% is the white circle. So the higher the concentration, the better the control. But when we get to that dash line, when we discontinued the drops, we could also see that the higher the dose, the more rebound that we had, except for the 0.01%, which really didn't have much of a rebound at all. So what they did is they took the 0.5% and the 0.1%, discontinued those, and had those kids go into 0.01%. And they found, okay, well, what we thought was placebo actually works really well as a myopia control option. So this is the new standard of care for atropine. Let's prescribe 0.01%. So then the LAMP study came along and they looked at even lower concentrations. So 0.01%, 0.025%, and 0.05%. And they had a legitimate placebo with saline as well. And these kids, 380 of them, were to receive 1 drop every night for 2 years. They found that the 0.05% had the greatest level of control, which is about 67% over the 2 years. And at the 1 year mark, if you look at 12 months there, they actually switched over the placebo group for ethical reasons to the 0.05%. Just because they knew that they were doing these children a disservice by continuing to watch their myopia progress. So one of the things that was brought up in the LAMP study was, sure, the 0.01% did have some level of control in the LAMP study, but it really didn't align great with the axial control. And that was seen in the ATOM study as well, but nobody really talked about it. It just became like the standard of care to prescribe 0.01%. As mentioned, I don't think anybody really knows why they don't align well, but I think it makes sense that you would want the axial length to closely match the refractive efficiency, because that increasing axial length is what causes all of the myopic complications when you look at our risk for disease with high myopia. And then when we look at side effects, when we look at 0.05% atropine compared to others in the beginning, like photophobia in the first 2 weeks, there were a good percentage of patients that did complain of light sensitivity. But after being on that a little bit longer, it really wasn't as much of a concern. And really, even the placebo felt like they wanted photochromic lenses. So, who knows how much you can really rely on subjective reports from kiddos if they know that they might get some cool photochromic lenses if they say that they do have light sensitivity. Similarly, with the accommodative amplitude, there was a little bit of a reduction in the accommodative amplitude in the beginning, but definitely got a lot better after about a year of wear. So if we have a normal accommodative response, then we know that kids have enough reserves to be able to still see very well up close. And there really wasn't a significant difference between these kids requesting help up close with progressives, for example. So overall, the 0.05% is tolerated pretty well. And the study concluded that over 2 years, the efficacy of the 0.05% was so effective, and that it should remain the optimal concentration during this study. So there still is a phase 3 and a phase 4 that has yet to be released, where they'll look at rebound effects and long-term side effects with atropine. So that should be coming out relatively soon. So if we know that atropine, if we want to do atropine, unfortunately, there's not really a basically like a protocol on how to go about prescribing atropine. There is one paper that I looked at that suggested a protocol that I put on here. They suggested that you start at 0.05% and continue to check the refraction every 3 to 6 months. If you see that there's good stability, then just continue to monitor at 6-month intervals, and then consider discontinuing once we see that there is good stability for, a period of time. Whereas if you follow them every 3 to 6 months and you're starting to notice progression, then you could either increase the strength by 0.01% until you see that good stability is noted, and then continue to monitor. Or you could prescribe combination therapy with a contact lens modality like orthokeratology or multifocal. And we know that they work better synergistically, which we'll go over in a moment. And if that still doesn't work with combination therapy, then we still have the option to increase by 0.01%. Once we start getting into the more customized versions of atropine, you would want to start working with like a local compounding pharmacy for that, because that's not available with Imprimis or Optum RX that I'm aware of. So what are some of the proposed mechanisms of action for atropine? It was originally thought that atropine blocked accommodation, so that is what slowed myopia. But that's unlikely, because a lot of the studies that were performed on myopia control were done in chickens that don't even have muscarinic receptors in their ciliary muscle. So that couldn't have been where the level of control was happening for those studies. And then there were, so that's basically without an accommodation system, a lot of species still showed a great myopia control effect with atropine. So it's thought that it can occur in either the retina, choroid, or sclera, or maybe all of them, or maybe a couple of them. At the level of the retina, we see that atropine does cause a release of dopamine, and dopamine has been found to be effective against slowing myopia by thickening the choroid. And then atropine, we do see that when you prescribe it, there is a pretty significant choroidal thickening, which could maybe be protective against thinning secondary to hyperopic defocus. And then lastly, at the level of the sclera, atropine may have effects in preventing any sort of elongation of the sclera itself by preventing synthesis of some of the growth factors of the sclera. So since atropine and the contact lens modalities work on different mechanisms, we know that combination treatments have a synergistic effect. There are a few studies that looked at spectacle options with atropine as well. And if you combine atropine with progressives, you certainly see a lot more control than if you were just to have progressives alone, and then certainly single vision glasses. There are a few studies that also look at atropine and orthokeratology. And again, there's a synergistic effect where With orthokeratology, after about 2 years, there was a 0.19 millimeter elongation over that 2 years versus the combination of orthokeratology and atropine, where it was just 0.09%, which is, or 0.09 millimeters, which is pretty significant. There are some ongoing studies. I believe Dr. Walleen and Dr. Moody are working on the combination treatment of atropine and multifocals, but that has not been released quite yet. And you can see that with the study with the atropine and the orthokeratology, the combination group, that effect did last over time as opposed to just kind of settling out. So what about the future? What are some of the options that we have on the horizon? One of them is the myocyte DIMS technology, which was developed by Hoya. And basically this technology are these little lens segments that have about plus 3.5 diopters of myopic defocus in the periphery. And the kid would look through the central zone for their distance correction. And that, of course, induces the myopic defocus. The Stellest Halt technology has little lenslets as well that also produce myopic defocus. And then the dot lens technology, this is something that's a little bit different in that they reduce the peripheral retinal contrast compared to, your on-axis central vision. And that was based on some of the theories that perhaps some of the high contrast signals that you get outdoors, for example, may have an effect on axial elongation. So really cool technology that is available in other countries and may be available to us relatively soon. So that is the extent of what we have available right now, the multifocals, the orthokeratology, and atropine. If you guys have any questions now, please put them in the chat and I'd be happy to answer. I also have my email here if you would like to ask me any questions, have any comments. If you need help like with practice management stuff, I love helping with myopia management. It's a passion of mine and I'd love to hear from you.
Awesome. That was incredible. And I never get tired of listening to all of your amazing experience. And you just do such a great job explaining the studies because there's so many of them out there. And when you read through it, especially if you're not somebody that's super familiar with myopia control or, some of the clinical research can be really hard to understand. So thanks so much for breaking down kind of what it was, who was included, what are the results, what does it mean? I just loved it. So thank you so much. I have a few questions for you that have come up on lots of different webinars and just common things that I'm always getting questions about. And I'd love your answers. So if a child is unable to insert and remove their lenses at the training visit, do you have the parents assist or are they just simply not a good candidate?
Yeah, I love that question because that happens all too frequently with our kids where they don't want to put contact lenses in, they're terrified. So I hate the response, it depends, but I'll tell you a couple of scenarios. One is, when you have parents that are really motivated to have their child in myopia management, then usually they're more than happy to assist. One of the tricks that we do is we'll actually put anesthetic in the eye and have them practice putting contact lenses in, just kind of like the physical motion of it. And once they physically have it on their eye, typically they feel better and more excited about the fact that they can see so good without their glasses on their face, and it makes them a little bit more motivated.
That's a really good tip.
Yes, that's worked really well. If I am going to have a child come back for contact lens insertion and removal training. At their visit, I'll show them how to put drops in their eyes, and it helps if you put them in like the refrigerator and have them practice putting it in 3-4 times a day. And then they get kind of used to manipulating around their eyes and something cool touching their eyes. And that's been helpful for us as well.
Oh, that's great. I remember learning a while back when I was first starting to practice like certain tips and tricks for patients that just could not get lenses in their eye, and usually like younger kids and things. And I remember one of my professors said, well, what you can do is you can have them wash their hands and then put an eye drop on the tip of their finger and like practice putting that on the white part of their eye, or something like that. And
Oh, that's
so one
great.
of our most recent patients, he was struggling a bit. So that was his homework over the weekend. And then he did a lot better at the actual training session. So thanks for
Oh,
sharing your
great.
stories. So I have another question. How, if you want to get started with myopia control, but you're not really sure how to get started, are there some resources that you would recommend?
Yeah, I think, one, your reps are always amazing resources to reach out to. Um, they're so knowledgeable and have, all of the resources that you can have for your office for patient education, and also have the ability to help kind of train you on how to be successful. I also really love review of myopia management. They have lots of great articles that are everything from science kind of broken down to practice management tips. Of course, doing CEs, things like that.
Yeah, that's great. I mean, I feel like if you just kind of searched any of the resources that you mentioned, there's like tons and tons of things that pop up, and I think there's so many doctors out there that really want to help. And then, like you said, if you have a rep with whatever modality you're interested in, they certainly want you to succeed, right? They want that. It's important for them to succeed so that everyone wins, the patient, the doctor, and the company. So I love that um, thought. Another question that comes up all the time, and I'd love to hear your advice. If you have a patient that has higher amounts of myopia, or especially if they're younger, so you're thinking, oh my gosh, they're already like a certain prescription at a very young age, do you implement a dual therapy, or do you always start with monotherapy?
That's a great question. I would say my personal opinion would be to start with monotherapy. And if they have a great response of it, then you're saving your patient some money. So I would start monotherapy and monitor pretty closely. Well, what do you do at your practice?
Same thing. And that was a recommendation from Dr. Justin Kwan. I had reached out to him when we had a really, really high myope, like a -6, and they were like 7 years old.
Oh,
I'm like,
wow.
oh my gosh, what do we do here?
Yeah.
And I was thinking of doing like atropine and some sort of contact lens at the same time, but he highly recommended just doing one, and then kind of remeasuring and tracking the progress in a few months. So that's what we do now. We just kind of start with monotherapy. That way you can see how effective one thing is, then check
Yeah.
them, see what's going on. And if you're like, oh my gosh, the axial length keeps growing, more than what we want, then we can implement something else. But yeah, I agree with you. I think monotherapy has been kind of the number one thing that I think most practitioners are doing, and probably what most doctors who teach about myopia control are recommending.
Yeah. And I think, I mean, when you do combination therapy, it's an awesome option because if you think about, with orthokeratology or the multifocal, you're allowing them to be able to get with a little bit more of a dilated pupil more into those treatment rings or treatment zones. So I think it's a great option when it's necessary.
Yeah, absolutely. Well, we are at the end of the CE event. I don't know if you had any last words, Dr. Cerenzie, that you wanted to leave people with?
I would say, get out there and do the dang thing because we have a really cool opportunity in our profession that I don't think any other profession has, where we're literally saving vision and providing a improved ocular health outlook for these children. And I just think that that's so cool that we have that opportunity that's backed by all of this data. So go get them.
I love that. I just think that this is such an exciting time in optometry. It's, something that wasn't really available years ago, and now it's like really made its way to the forefront. And I think that more and more optometrists are going to start recommending myopia management options to children now, instead of just being like, well, maybe we can. It seems more like getting involved now is like definitely the right time. So thanks so much for everything. And thank you to all the attendees for joining us this evening. You've got Dr. Cerenzie's contact information. Please email her with any questions, and we will see you at our next event. Have a good night, everyone.
Thank you, Dr. Wu.